Hey, my name is Caleb Wynn, and I am at the Emory University Medical Imaging Program, or I'm in it rather. I'm in the administration track, and today I'm going to be presenting an article for pharmacology, and it's my journal club article, not my article summary like I was supposed to do the first time. Sorry about that. And so let's get started. The objectives that I have today, we're going to discuss the article, we're going to discuss its topic, its purpose, its reasoning, and its goals. We're going to also examine hydromorphone and fentanyl's general characteristics. We're going to talk about those as well as their adverse events associated with them. We're going to highlight the study's methods, subjects, reasoning, and other variables. We're going to examine study results on hydromorphone's effectiveness, effectiveness being how well it works for pain, as well as how little it causes adverse events and how little those events are. Like, are they coding, or is it just like a little they drop their O2 stat to like 93 or something. We're going to discuss the results in relation to analgesic effectiveness and adverse events, as well as potential usefulness for the future. Then we're going to describe the limitations of the study and what may need to be done for further, and we're going to conclude the results and findings. So here we go. So hydromorphone hydrochloride use during various interventional radiology procedures, pain control, and adverse events. A case series audit analysis. That's the article that we're going to be talking about. That's the title of the article. Here are my authors right here. The purpose of this article was to examine pain control and adverse events while using hydromorphone, which is known as Dilaudid, in combination with Versed. And I don't know how to pronounce that. I know it's like benzodiazepine, midazolam or something, but we're going to call it Versed for the remainder of the study, or remainder of the presentation. And then so some reasoning behind this study. Less procedures are being done in the OR. More procedures are becoming less invasive, so they can be done outside of the OR and without anesthesia teams. They don't need general anesthesia, or they don't need MAC anesthesia either. So they can get by with moderate sedation many times. So there's been an increase in this, and an additional goal of the study was to also compare the adverse effects of hydromorphone to the ones from fentanyl. We're going to compare both of those in a sense. So, hydromorphone. It's an opioid used for analgesia. Essentially just a big word for pain. It's just a pain medicine. It's 4 to 8 times stronger than morphine. So it has the pain potency, so to speak, 4 to 8 times higher than morphine. It takes into effect about 15 minutes after IV administration. So as soon as it's pumped through, about 15 minutes later, the effects start taking place. The results, it can and usually results in respiratory depression. So whether it be extreme or just a little, most of the time it results in respiratory depression from the sedative hypnotics of the drug. And there are no known drug-specific reactions. So using it with Versed would be completely fine. So fentanyl is also an opioid for pain, and it's 100 times the pain potency or analgesic potency of morphine. So we talked about hydromorphone, it was 4 to 8 times, fentanyl is 100 times, so that's pretty significant. It goes into effect almost immediately. So you got 15 minutes compared to just like that. So far fentanyl is 100 times, so it would be more effective in stopping the pain, right? It would be more effective in controlling pain from patients in IR. So, however, in large doses, it alters the respiratory rate, the alveolar ventilation, as well as the CO2 sensitivity, and it can lead to apnea and hypoxia, which would decrease O2 sats, essentially. Stiff chest syndrome. So it can also lead to stiff chest syndrome, which is a very rare but very serious reaction from fentanyl. So stiff chest syndrome, is when your thoracoabdominal muscles contract after the administration of fentanyl. So your thoracoabdominal muscles are contracting, you got a stiff chest, and so this is a problem. And this is a problem that some, regular nurses, not in anesthesia, like not CRNAs or not anesthesiologists or AAs, that they're not maybe familiar with, and therefore don't really know how to treat this reaction. So fentanyl could potentially be, it could be kind of contraindicated for this reason right here. So the methods of the study, there was 100 patients from Louisiana State University Interims Hospital IR department. It was a retrospective and consecutive study with procedures from July 31st, 2013. Excluded these people. Excluded people under the age of 18. It excluded prisoners, people with mental incapacitation, and people who have been admitted to the hospital for greater than 30 days. All those people were excluded. Age, sex, the types of procedures, comorbidities, hydromorphone dose, Versed dose, pre-intra, post, and pre-intra and post pain scores, opioid-associated nausea, lightheadedness, and the antiemetic administration having to be used, naloxone, hydrochloride, which is just Narcan, hypotension, when your blood pressure, your systolic became less than 100, hypoxia, when your O2 sat became less than 93, and PACU admission, if the patient's reactions were too great for the regular nurses or the regular team to deal with. All of these things were examined, and there were variables associating to the effectiveness of hydromorphone. And then pain scores determined, we talked about here, the pain scores, the pre, intra, and post. They were determined verbally by nurses with your average pain score, what's your pain scale from 1 to 10, with 1 being none and 10 being the worst. And then they also used Wong facial pain score. So that was also used maybe during the procedure, or if the patient was not cooperative or not talking very much. The results. So they consisted, the 100 people consisted of 52 men and 48 women. The age was not statistically significant, so there wasn't really a whole lot of difference there. The pre, intra, and post-procedure pain scores were similar among sex, except during the abscess drainages. So during abscess drainages, men experienced the most pain. And then highest pain score reached was 3.5, and it was post a nephrostomy tube for a female. So that was the most pain experienced after the administration of hydromorphone. The adverse events that came about, we had some nausea and vomiting. 1 man and 3 women experienced nausea and vomiting. However, just because 2 more women than men experienced more nausea and vomiting doesn't mean that you're more susceptible to it if you're a woman. Those are kind of statistically insignificant. And then those patients received an antiemetic like Phenergan, a medicine to help with your nausea and your vomiting. And then hypertension after total dialysis catheter. So this hypertension occurred after 1 patient had a total dialysis catheter put in. Their pressure dropped to a systolic pressure of 63, so which is lower than 100, obviously. And this was 1 woman after 2 hours after the administration. So it's hard to say. We'll get into a little bit more of the discussion later. And then hypoxia after nephrostomy placement. 1 patient experienced that. They went from an O2 sat of 94 to 100 on O2 levels of 2 liters and of nasal and then they went to 89 to 91% after 1 hour post-procedure. And then the adverse events continued. There were no PACU admissions, and there was no Narcan given or needed. So no patients crashed or had serious events to where they couldn't reverse them otherwise or take care of them with more conservative avenues. So some of the discussion. Hydromorphone was successful in controlling the patient's pain. It was safely controlled. 4% of patients either vomited or received antiemetics. And then 1% experienced hypoxia, which would be attributed to the removal of the procedure stimulus. So they're saying that the hypoxia was due to the lack of procedure stimulus. Once it was over with, since it was 1 hour after, they're saying that the lack of stimulus kind of attributed to the hypoxia. And then they're also unsure if this 1% of hypertension that we talked about earlier with the patient with the dialysis catheter, they're unsure if it was due to the hydromorphone or other conditions relating to dialysis. So, because it didn't happen until the patient was actually on dialysis. So, they do believe, however, that it did attribute to the severity. So, if their blood pressure was going to drop in dialysis anyway, the hydromorphone did attribute to the severity of it and making it worse. And then the conservative treatment was for all adverse events. There was nothing crazy. They didn't have to tube anybody. They didn't have to call a code or anything like that. Everything was a conservative measure and a conservative treatment. And then some more discussion. So there's no prior literature to using hydromorphone for these types of procedures, for perio-procedurally, which just means before, during, and after the procedure. So there's none of that can be found. It was primarily used before this study for just chronic pain that ranged from moderate to severe. So it wasn't really for moderate sedation. It was just more so for chronic pain. And then the potential increase of the use of hydromorphone is expected. So with some of the things that fentanyl, some of the adverse events that fentanyl has, then if hydromorphone has less adverse events and proves to still be effective, then hydromorphone may very well be replacing fentanyl as one of the most common moderate sedation. So some of the limitations, which I definitely agree with, was they said they had a small sample size. They only had 100 patients at one hospital. So this is extremely small. And then so this calls into the representation of the cases. It's suffering because with 100 patients, you're not going to see every single IR procedure. So this also led to the historically most painful procedures not being observed. So some of the IR procedures that are most painful were not observed, and so therefore they couldn't see hydromorphone's effect during those procedures. So the results may have been different if that were the case. And then, of course, always a retrospective study is limiting. It has a limiting nature. A prospective study would be most suitable, so that you could examine, right then and there, and then compile data for that you can see as it goes and just go through the entire process. So they believe that would be better. And then, so the conclusion: evidence supports the claim that hydromorphone can be used as a safe and effective analgesic for our procedures. To determine the clinical efficacy and cost effectiveness, larger sample sizes are needed. So essentially, there definitely needs to be some more studies going on. But at my current workplace, we use moderate sedation on every case just about. What we use is fentanyl and Versed, kind of like exactly what they were comparing hydromorphone to. And I think we do a pretty good job of not having adverse events and sedating them properly. However, some things just you can't control. It happens. The patients, you don't know how their body's going to react. You don't know how they're going to react to the procedure or the medication. So if fentanyl does have more adverse events, then this would be very beneficial to us in seeing that hydromorphone would be more effective and at least more safer. So I think there definitely needs to be more study done. I would be very interested to further study this and to see if hydromorphone is actually a lot better than fentanyl, because then we could make some changes at our current place right now. And so I know, do you have any questions?
Mm-mm.
You don't have any questions? I know you're a nurse.
I don't.
Okay. All right. Well, thank you.